But in the future, I plan to require that just as the textbook, as long as it's available. So I say go ahead and watch it now, but if you're not in 2009, if you're in any future year, you may be required to watch that. So now let's transition to the next set of this, the next lecture in this series. So in lecture 3, we are talking about ventilation. And in ventilation, we consider the total pulmonary ventilation is greater than the alveolar ventilation because of a dead space. So we do not get gas exchange in the trachea and the bronchi and bronchioles. So the total pulmonary ventilation equals the ventilation rate times the tidal volume. What was the tidal volume? 500 mLs, or a half a liter. Very good. So now let's think about ventilation in this cyclical fashion here. So we start with number 1. We have a dead space filled with fresh air, about 150 mLs, and we have 27 mLs at the end. Excuse me, at the end of respiration. So our key over here is the PO2, the partial pressure of oxygen, is about 150 millimeters of mercury in fresh air. The PO2 is approximately 100 millimeters of mercury in stale air. So number 2 here, we have the exhaled half an ml at tidal volume. So we get down to 2200. So already I think these are just a little different than what we had seen before, but that's fine. I think we're going from 2800 to 2300. This is somebody else that does 2700 to 2200, but the difference is still the same, the half a liter for tidal volume. So the first exhaled air comes out of the dead space, only 350 mLs leaves the alveoli themselves. And then here, shifting to number 3, we're at the 22 and 150 still. At the end of expiration, the dead space is filled with stale air from the alveoli. And then number 4, the inhaled 500 mLs of fresh air at tidal volume. We see that the dead space is filled with fresh air. Only 350 mLs of fresh air reaches the alveoli, along with that 150 that was the stale air, right? And so what you end up with at peak PO2s in the alveolus is not the same as what you find in the atmosphere. So it's not a perfect exchange of all the old air goes out, stale air, and only fresh air comes in. So it is a mixing that goes on. And that mixing has to have a high degree of efficiency, and it's the rate of respiration and flow, as you know, when you start breathing fast and hard, right, that have to change to maintain that efficiency, or to bump it up a little bit so that you can blow off more carbon dioxide and still bring in a very high amount of oxygen to get oxygen into the blood. So keep these dynamic processes and changes in mind as you're just thinking about baseline events here. So with ventilation, you have alveolar ventilation equals the ventilatory rate times the tidal volume minus the dead space volume. So if we're going to correct it for the known biophysical properties based upon the limitations from the anatomy. So the effects of breathing pattern on the alveolar ventilation is shown on this slide. We're considering tidal volume on the left, ventilation rate or breaths per minute, then total pulmonary ventilation in mLs per minute, fresh air to alveoli, the tidal volume minus the dead space volume in this column, and then alveolar ventilation mLs per minute in the far right. So under conditions of tidal volume, under normal conditions, 500 mLs, the resting ventilatory rate, ventilation rate, I say ventilatory rate is 12 per minute. Remember, breaths are not really units, so this is just per minute, right? So when we make any formulae to calculate anything, we don't use breaths, just like beats per minute with the heart. Cardiac output was stroke volume times heart rate. We didn't keep beats in there. We just ended up saying that the cardiac output was mLs per minute, right? Excuse me. So the total pulmonary ventilation is mLs per minute is 6,000. So it's 500 mLs times 12 per minute, and we get 6,000 mLs per minute. Then the fresh air to alveoli is 350. It's the tidal volume minus the dead space, so 500 minus 150. And then the alveolar ventilation is 4,200. Excuse me. So the alveolar ventilation is the ventilatory rate, where's that, 12, times the tidal volume, 500, minus the dead space volume, and that gives us the 4,200. Then with the shallow breathing at 300, you have a rapid ventilatory rate at 20. Then we still have 60,000, 150 for dead space, excuse me, for the difference. Okay, so this is the difference here. Sorry about that. So I was thinking that. So 350 times the 12 is giving us the 4,200. So 150 times the 20 gives us 3,000. And then with deep, we have slow and still 6,000, but we have the fresh air to alveoli, the tidal volume minus the dead space at 600. So we end up with 4,800. So going from normal 12 to 750 at 8, we bump up alveolar ventilation by 600 mLs per minute above baseline. But when you breathe rapidly and shallow, then you can drop by 1,200 mLs per minute. So these are very important parameters to understand because you can compensate for exercising quite well, and it may even be a little more challenging than to breathe too fast and lose the capability to ventilate the alveoli. So in other words, when you hyperventilate, you're not effectively ventilating the alveoli. So the types and patterns of ventilation then, we need to recognize these as helping us understand physiology, but obviously clinically as well. So eupnea is normal quiet breathing. So eupnea is the normal state. Hyperpnea is increased respiratory rate and or volume in response to increased metabolism, such as exercise. Hyperventilation is increased respiratory rate and or volume without an increased metabolism, as we just talked about. So this can be emotional or blowing up a balloon. The hypoventilation, the decreased alveolar ventilation. Shallow breathing, asthma, restrictive lung disease are examples of this. Tachypnea is the rapid breathing, so tachy is increased rate, as you recall. Usually this is increased respiratory rate with a decreased depth, so this is panting. Dyspnea is the difficulty breathing, so it's a subjective feeling sometimes described as air hunger. Various pathologies are related with dyspnea. It's just that really the difficulty breathing, whether it's perceived or real, the patient is experiencing it. With hard exercise, so we've all experienced that, whether that by our definition is just walking up one short flight of stairs because we're so out of shape, or we just ran 10 miles. We appreciate dyspnea. So apnea is the cessation of breathing, so the voluntary breath holding or depression of CNS control centers. Continuing then to consider the normal ventilation values in pulmonary medicine. So the total pulmonary ventilation is 6 liters per minute. Total alveolar ventilation, 4.2 liters per minute. The maximum voluntary ventilation, 125 to 170 liters per minute. So notice that we're up to higher values here. Then the respiration rate, 12 to 20 breaths per minute. So we may have been considering mLs per minute as we're going along. Now we are converting it, and we see that sometimes clinically different values are used. We must always look at units and convert when we need to. So with ventilation then, as the alveolar ventilation increases, alveolar PCO2 PO2 increases and PCO2 decreases. So this is a very important way to read graphs, as you know. So let's identify our axes. On the x-axis, we have alveolar ventilation, liters per minute. On the y-axis, we have alveolar partial pressure, or the partial pressure of the gas in millimeters of mercury. And we're looking at two of these. The red line is the PO2. The blue line is the PCO2, deoxygenated and oxygenated blood. Thank you very much. Good color coding. So in this case, we're not looking at the change of one variable with time. We have two dependent variables, and we're seeing how they change relative to each other. So we don't know, well, hypoventilation and hyperventilation. So the ventilatory rate is the independent variable that we would instruct the research subject to change on their own, right? So normal ventilation is the 4.2 liters per minute that we said. So we see the PO2 is right close to 100. The PCO2 is right about 40 partial pressure, right? So in millimeters of mercury. Then what we're doing in this case, because we have two dependent variables, is we're performing a correlational study. As you change alveolar ventilation in liters per minute, what is the correlative change in the alveolar partial pressure for the different gases? So with hypoventilation, we see a near linear drop in the PO2 over 2 liter per minute change in alveolar ventilatory rate. We see a drop from 100 to 30, so a drop of 70 millimeters of mercury. And it's quite linear. We see that CO2 increases from 40 to 100, so over the same relative change in alveolar ventilatory rate, we see a 60 millimeter mercury increase in PCO2, which is actually worse than the oxygen drop almost, but the two combined create major problems. Notice that this is not quite as linear as what they're showing for the oxygen. So as and again, I try to remind we try to remind ourselves of drawing the tangent to the curve, and then seeing how the slope of that tangent to the curve changes over the spans of the x-axis. Right? So the slope of that line is going to get greater and greater and greater. So the PCO2 is accumulating faster and faster and faster with each incremental decrease in alveolar ventilatory rate when someone is hypoventilating. So in other words, the faster the breathing rate decreases, then the faster the risk that the person is holding too much carbon dioxide. And when we get to pH, we know that is really important. If you blow off carbon dioxide, you see how rapidly that can occur with increasing the ventilatory rate, alveolar ventilatory rate. flow rate is what we're talking about here, right? Then you blow off carbon dioxide quite effectively to go from 40 to below 20. Okay. And then, of course, the PCO2 goes from 100 to 120. So it looks like you can get an increase of 20 for the PO2 and a decrease of 20 for the PCO2. So a balance. But again, remember, a drop of 20 for PCO2 can possibly have more dramatic physiological effects than just the increase in the PO2. They're targeting different systems. This change will affect acutely blood pH, whereas the change just in the oxygen will not. Okay, so these are some of the characteristic features of under normal relationships as we saw there. So you need to struggle to learn how to read graphs and understand how you convert that into ideas. Ventilation, the local control of arterioles and bronchioles by oxygen and carbon dioxide. So we talked about locally metabolic tissue effects on the arteriolar constriction and relaxation. With the circulatory system, we bring it back now to see how it interrelates with bronchiolar effects. So the gas composition is in the left. Then we talk about bronchioles, pulmonary arterioles, and then systemic arterioles. So remember, pulmonary circulation is separate from systemic, and you can have regional distinctions between them to meet the needs that are there. So we note there's an asterisk here. The parentheses indicate weak responses. So with PCO2 increases in the gas composition, the bronchioles will dilate reflexively because if you've got CO2 around, you know you need to dilate to be able to blow it off. You have to get it out of the alveoli somehow. And then the pulmonary arteries will constrict, but it's not that big of a deal. The systemic arterioles will dilate. The PCO2 decreases, then you're going to get a constriction, and the arterioles are not playing a big role in what's going on here, and the systemic arterioles will constrict. So these are systemic responses to the blood PCO2. The PO2 increases is not going to have a big effect on the bronchioles or the pulmonary arterioles, but you're going to get a constriction in the systemic arterioles. So you can see basically the two stimuli that will be typically coordinated. If they're discoordinate, then you kind of have a problem if you have a high PCO2 and a high PO2 because you got somebody on a really high oxygen and they're not effectively blowing off the CO2, let's say. You can end up with some confusion because things are discoordinate. But typically, under normal conditions, you'll have the PCO2 is going to be lower in the arteriolar blood, and the PO2 is going to be higher. So when they are working together like that, you're going to get a slight constriction of the systemic arterioles because you don't need to deliver more oxygen than what is needed by the tissue. If the tissue is highly metabolically active, then it's going to add PCO2 and dilate to offset that. Excuse me. The PO2 decreases, then you're going to get pulmonary artery constriction and a dilation of the systemic arterioles. So you see the dilation with so what you're going to do is you're going to dilate when you need more oxygen delivered and you need to wash away the carbon dioxide. So hopefully that makes sense to you. This is a coordinate response and this is a coordinate response. Because typically if you have an increase in PCO2 with the tissue where the arterioles are, systemic, think of a skeletal muscle, you're going to want to dilate to bring more oxygen because the oxygen is lower too. So you dilate with the lowered PO2 and higher PCO2 to bring in more oxygen and wash away the carbon dioxide. And this is coordinate as well. If too much oxygen is coming at you, you constrict to meet your metabolic needs. So you don't take more than what you need. And extremes on either side are risky. Too much oxygen around when you're not consuming it can cause oxidative stress and damage to the tissue as well. Excuse me. So continuing on with our ventilation then, the local control mechanisms attempt to match ventilation and perfusion. So that's what we were talking about. You've got to keep the blood flow to match the demands. So this happens at the systemic circulation as well. I almost said as it does, but that's wrong because they're slightly different mechanisms as you just saw. But you also get the coordination of flow and demands to meet the gas needs at the alveoli. So normally perfusion of blood past the alveoli is matched to the alveolar ventilation to maximize the gas exchange. So we see the arterioles coming in. And remember, we're going to have a high PCO2 here and a low PO2. So when we think of the arteriole coming to the alveoli, it's the opposite of what's coming to the systemic circulation after the lungs, right? So we go back to this table. What's being delivered here in the arterioles is a different blood than what is being delivered in the pulmonary arterioles. Pulmonary arterioles are going to have a high PCO2 and a low PO2, so you're going to get some pulmonary arteriolar constriction with each fresh injection, with each stroke volume coming at it, right? With each ejection phase of the heart, you got right ventricle, you've got new deoxygenated blood coming in to keep a certain level of constriction. Anything that would enhance the amount of carbon dioxide, like when you first start working out and more carbon dioxide gets into the blood than what you're getting out through the alveoli, then PCO2 is going to increase, be higher in this blood coming at the alveolus than what got there just before it, and you're going to get the response. And so this is to match it. So then when ventilatory rate increases, then you'll get the reversal of that. So if there is a mismatch, then you don't get the effective exchange. So you can see here that the blood that gets by is not properly oxygenated, and you don't get the full oxygenated blood coming to the left heart. So anything that creates the homeostatic imbalance in this ventilation perfusion control mechanisms will cause a decreased oxygenation of the blood coming to the left heart. So the local control mechanisms try to keep the ventilation and the perfusion matched so that you don't get this case that we saw with the mismatch. You get proper oxygenation. But it's a little more complex than that, because under normal resting conditions we don't use all of our alveoli. So when we talk about exercising and everything, that's when we'll talk about some alveoli becoming, recruiting more alveoli with deeper breaths and things like that. There are physiological responses to recruit all the possible or more of the total possible alveoli that we could use. Not all the blood going into the lungs is passing across an alveolus that is getting the properly matched ventilation. But it doesn't matter. We end up with the proper gas PO2s and PCO2s in the blood coming to the left heart. And when you place a greater demand on the system, you've got to adjust up to that and maybe even get higher PO2s depending upon the level of exertion So there's more than just the baseline ideas that are being presented here. Auscultation is a diagnostic technique, as you know, to listen to the lungs. Obstructive lung diseases, there's asthma, emphysema, and chronic bronchitis. My intention is to post a link to an additional presentation that includes discussions on these topics, should you be interested in that additional material to help you expand your studies. So we see the summary here. I'm not going to take the time to go through it. We took 3 lectures to cover this material. It is very important to understand respiratory physiology. The next lecture will be on a separate chapter that talks just about the gas exchange and what the PCO2s and PO2s are of the blood and oxygen carrying capacity, and we'll get back to our hemoglobin. So thank you for your time and